Okay. Yeah, here she is. All right.
Person to person to find them.
All right. Well, for those of y'all who don't know, I'm Dr. Anglyn, and this is my medical student, Adam Anglyn.
Right.
I've known this medical student for many years.
All his life, huh?
And may have we're working together this month, and hopefully in a few more years we work together a whole lot. So that might work out. So we'll try. All right. Okay. Let's see. Today we're going to sort through some of the cancer screening recommendations, and this can be a source of confusion for both physicians and patients because there are no one set of recommendations for screening tests, and we're going to see some of that today. We can talk about some things about cancer, the ones we screen for, some of the specific recommendations and exams to do. And the only test is going to be when you go, hopefully what you'll do is have a more understanding really of when you go to get your physical, what test is appropriate to have done at what time. And so how does cancer start? Well, it begins in our cells. Our cells are constantly replicating. A good, strong immune system, we think a lot of times people, fight cancer cells off throughout their life somewhat. Normally, body forms new cells as they need them, replacing old cells that die, and sometimes something will go wrong and cancer cells will develop. And if our body doesn't kill the cancer cells that get started, then we start struggling with cancer. And then therapies are designed to try to kill the cancer cells that our body didn't kill, or help our body start killing them. All right? Now, it's not just one disease. There's a lot of different types of cancer. We got here more than 100 different types. And you can break them down to different stages. So, but they're often named for where they start. Lung cancer starts in the lung, breast cancer starts in the breast, prostate cancer starts in the prostate. If it goes somewhere else, for instance, prostate cancer goes to your bones, or if your breast cancer goes to your brain, that's called metastatic brain cancer. Metastatic cancer. Because it's gone, the primary site is somewhere else and it's spread to another location. Obviously, our goal is to try to prevent cancer, and one of the things you don't want to do is to have metastatic cancer. If you do, treatment is more complex. It's a more difficult situation to deal with, so we'd like to keep it from being metastatic. Cancers that affect men and women, we're just going to talk about some of these. There's, like I said, there's over 100 of them. But we wanted to talk about ones that specifically have some form of screening test. Skin cancer, men and women can get that. Actually, one thing that protects you, African American folks don't have much skin cancer. They do, they can, but they don't have very much because their pigment protects them. The people who have skin cancer the most are people who are probably of Scotch-Irish descent, Scandinavians, people with very blue eyes, blonde hair, fair skin. All right, oral cancers, mostly seen in people who smoke. Lung cancer, mostly seen in people who smoke. Esophageal cancer, seen in people smoke, drink, and people with reflux. Bladder cancer, seen a lot more in smokers. And then colon cancer. So, cancers that affect women primarily. Now, men can have breast cancer. In my practice, in 30 years, 2 men with breast cancer I've seen. And that's, a lot of people can practice 30 years and never see a one. As far as a man with breast cancer, I've had 2. But breast cancer is mostly in women. Cervical cancer is in women. Ovarian cancer and uterine and intermediate cancer. Okay. Men, prostate cancer and testicular cancer are the 2 we're going to talk about today. And so what we're going to do is go over some of these screening recommendations and try to sort through all that. Now, the U.S. Preventative Task Force, have y'all heard of that? In medical business, we hear about that a lot. Especially, we're concerned, it was created in 1984. It's an independent volunteer panel of national experts in prevention evidence-based medicine. They work to improve our health by making evidence-based recommendations about clinical preventative services, screening, counseling, preventative medications, and they make a report to Congress each year. So doctors are kind of like everybody else. Anything that is done by a government agency kind of thing, we're always a little bit skeptical of. So not everybody agrees with what the U.S. Preventive Task Force comes up with. But it's a useful thing to look at. And they set a lot of guidelines. And the more we move to a one-payer system, this is probably what's going to drive what's paid for. So I would suspect. Now, and they try to help us decide what preventive service is right, looking at large population-based studies. The thing you have to remember about, a doctor and a patient is a one-on-one situation. When you look at screening studies and try to make recommendations for the population, you do it based on population studies. If very few people have this cancer at age, say, 35, we're not going to screen for it. Does that mean you couldn't get it? No. We all have patients who fall outside the screening recommendations who have certain kinds of cancers. They just didn't fall into that category. So it's based on population studies. There's some other organizations we'll look at. American Cancer Society has their guidelines, American Academy of Family Physicians, American College of ACOG, American College of OB/GYN, and then National Cancer Institute. We're looking also today at American Gastroenterology Association and the American Urology Association. So we've got some of those in there. And the problem where it gets complicated is that sometimes the recommendations by 2 or 3 different organizations may be different for the same cancer. So that does get to be confusing. Recommendations usually are the purpose and result of a study. Indicated in our lingo today is going to mean needed. Asymptomatic means you don't have symptoms. Certainly you would like to catch cancers early before people have symptoms. Morbidity, to the disease state and the incidence in population of morbidity. Morbidity means it affects you somehow with the disease. Mortality would mean deaths from a disease. And there's some acronyms that we use. A lot of questions about screening. And we look at whether you should be screened, not be screened, what's the effects of that, and what's the value of early detection. One problem with any screening test is, and why they look at this so hard is a lot of times you have a screening test that shows you may have a problem. For instance, every year a lot of women have, quote, an abnormal mammogram and have to have more studies. Most of the time they have no cancer. Most of the time they have no cancer. A lot of times they end up getting biopsies, and still a lot of times they don't have cancer. So you have to look at that. If you're doing 1,000 biopsies and only one person's got cancer, you don't need to be doing them. That one person needed it, but 999 didn't. So that's what you look at. That's kind of the way you have to think about this. Is it worth it? If you're just generating a lot of business for doctors and hospitals and it's not helping people enough, then we shouldn't be doing it. So you want to be sure it's helping. All right. Some people are at higher risk for cancer. You have to keep that in mind. Some people are at lower risk for cancer. Obviously, patients who smoke are at higher risk for cancer. That's the one thing the doctor and the patient have to keep in mind. People who have a lot of strong family history of certain kinds of cancers may be at more risk. So let's look at some screening recommendations. Skin cancer. The bottom line is here, I'll save you some time here, there is no recommendation for a particular screening test for skin cancer unless you're in a high-risk group. For instance, some people have dysplastic nevi syndrome. They may want to see a dermatologist every year. That means they have a lot of kind of weird-looking moles. So there are certain groups that may need that. Now, one of the things that I think probably most physicians do is when you're doing a physical exam on a patient, as you check the patient, you're looking to make sure you don't see anything that looks like skin cancers. I usually try to, when I do a physical exam, I always look at somebody's back because nobody can see their own back. I mean, even people who are contortionists, but even with mirrors it's tough to do. But so I don't even know what the middle of my back looks like. So I try to always look at the back because if somebody's got a skin cancer there, because the back a lot of times gets sun. Think about it. When people wear swimsuits, men go without a shirt. Women's swimsuits, most of them, the back's not covered, so the back gets a lot of sun. So skin cancers do pop up there. And the one you don't want to miss, of course, is melanoma because it can kill people. I mean, there are people in their 20s who die from melanoma cancer. So, now, the task force did recommend, even though they didn't recommend screening, they did recommend remain alert for skin lesions when you see them. Kind of makes sense, really. The American Academy of Dermatology recommends that persons at high risk, those with strong family history of melanoma and multiple clinically atypical moles, that's the dysplastic nevi, perform frequent self-examination, seek a professional evaluation of the skin at least once per year. One of the things I've done with some patients who have lots of moles and things, I've told them sometimes just to, get with their family member and make a picture. Take pictures now. It's so easy to take pictures now with cell phones. And just put pictures of your moles. And then if you say later, I think that mole's changing, we'll just look back at a previous picture and see if it's changing. So the bottom line is protect yourself from the sun. We try to get people to wear sunscreens, tan in beds, maybe even worse than sunshine. So we try to get people to stay out of the tanning beds. And there are no blood tests or x-rays to screen for skin cancer. Just if you see something on your skin that you think is a significant change, just get it checked. Now, a lot of times as you get older, people get things like seborrheic keratoses. And they can look gray, black, brown. They're very common. They're totally benign. But a lot of times it's easier for me to say it's a seborrheic keratosis than it is for you as a patient to say, that's just seborrheic keratosis, don't worry about it. So if you have questions, just be sure to check it out. Oral cancer. How many of you, when you go to the dentist, they ask you if you want to be screened for cancer? I know my dental hygienist, she checks around. They also have some kind of solution you can do now that they'll pick up something in some of the dentist offices. They do that. There is no recommendation really for screening, but a lot of the dental offices are doing that. The key thing for particularly if you smoke or use any kind of smokeless tobacco, if you have a sore in your mouth that doesn't heal, after a few weeks. You can get an ulcer in your mouth, and that sometimes takes 2 or 3 weeks to get rid of the darn thing. But if you have something like an ulcer in your mouth that doesn't heal up, or if you have a white patch in your mouth that just won't clear up, it should be checked. So regular dental exam is probably the best way to do this. Lung cancer. Now, up until just recently, we didn't really have any recommendations for screening for lung cancer. What we found out a long time ago is by the time you see a lung cancer on a chest x-ray, you can turn out the lights, the party's over usually. So we knew that chest x-rays weren't a good way to screen for lung cancer. So they did these studies. They've been going on. I had a number of patients over the years participate in this study, looking at CAT scans versus chest x-rays versus doing nothing. So what they've come up with here, the American Cancer Society has come up with some guidelines for CAT scans. And here's the guidelines. If you're 55 to 74, you can qualify for it. In fairly good health. The reason is if you're about to drop dead anyway, there's no need to screen for lung cancer because you can't survive the treatment. Because the only cure for lung cancer is surgery. If we can't cure it surgically, you can't cure it with chemotherapy or radiation therapy. Those are palliative, meaning they can't cure.
Why do they give it to you then after when you have lung cancer? They still give you chemotherapy and...
They're still trying to make, well, it depends. If they've already done surgery and they're doing that, they're just trying to make sure you don't have a reoccurrence, depending on the cell type. Now, you have to have at least a 30-pack year history of smoking. Now, if you smoke for 15 years, 2 packs per day, that's 30 years. That's 30 pack years. If you smoke 3 packs a day, you only got to do it for 10 years. If you smoke 1 pack a day, you got to do it for 30 years. And you either have to at least still be smoking or quit within the last 15 years. So if you've been quit for 20 years, you don't fall into this category. Now, the other thing on this one, I'm not sure a lot of the insurance companies are covering it anyway. But I know that some of the hospitals are offering a good deal on this because they know insurances don't cover it. All right. And this just explains about the trial. And it is a low-dose CT, which is good because then you're not getting near as much radiation as you would in a full-blown CT. That's the other thing about screening for cancers. While we're here and talking about CT scans, one thing I wouldn't recommend for screening, and you can get these at different clinics around Atlanta in the metro area, is these full-body CT scan screenings. You can go in and they'll do your abdomen, your pelvis, and your chest. I wouldn't recommend doing those. Could you ever find something? Yes, you could. The problem is they find stuff all the time. You end up usually having to have more and more scans to keep checking for usually nothing. They did one study where 1,000 people went in to do that. Over 900 of these people who felt well needed more scans to look at stuff they found. And you're like, and these were all asymptomatic people. It turned out they were all healthy people. So the total body scans, I wouldn't recommend those. Nobody that I know recommends those for screening. Plus you got radiation. The other thing is you do a total body scan today and you say, oh good, I don't have pancreatic cancer. All right, pancreatic cancer starts growing 2 weeks later. How often are you going to get a total body scan? And then you get so much radiation, next thing you know, you might have a cancer because of all the radiation you did. So you have to think about that. But this is low dose CT, so that's a better choice. And they actually recommend for the people who fit in that category doing them every year. So, and I usually talk to patients. Some patients elect not to do it. So, esophageal cancer, no real screen test for that, except for people who fall in a certain category with Barrett's esophagus, which can lead to dysplasia, which means changes in the cell types where they're not normal, and eventually cancer of the esophagus. This is not to be confused with our Atlanta Gastroenterology Associates. This is the American Gastroenterology Associates. Recommend against screening the general population. So who needs this test to look? This is where the doctor actually looks down and looks at your esophagus. Now, sometimes when people have got stomach issues, bad heartburn, they may get this done, men or women, and then they may find Barrett's and tell you have to be followed more closely. There's a couple of cell types of Barrett's. One of them is the one you have to watch for cancer changes, and that's not the most common one that's found. But the people they recommend considering this are men over 50 who are white, who have chronic reflux, hiatal hernia, they're overweight, elevated body mass index, and intra-abdominal distribution of body fat, tend to have a big belly. So, huh?
That's payback for the sauce.
So if you see a guy who's got silver hair, he's white, got a big belly, and he's popping Tums, he probably needs to be doing this. Okay. Here's another set of recommendation by the American College of Physicians. And this is people, men older than 50, with the following additional risk factors: nocturnal, meaning night reflux, hiatal hernia, elevated body mass index, tobacco use, which increases the risk of cancer, and intra-abdominal distribution of fat. So, and then upper endoscopy is generally recommended to people who are having dysphagia. Dysphagia means difficulty swallowing, weight loss, GI bleeds. Those may be people who might have cancers. A lot of times they're going to get that anyway. They're looking in their stomach. They got to go through the esophagus to get the stomach anyway. So, and again, doctor and the patient make that. Bladder cancer. Actually, there is no standard recommendation for bladder cancer screening. Now, the group of people who is the highest risk for bladder cancer are, anybody know? Smokers. Smokers have a much higher incidence of bladder cancer. So if you don't smoke, you have a less chance. Doesn't mean you can't get it, but there's no screening test. So if you look through this, there's really not, this is just telling you that there's no real screening test. Now, this is one I put in here. Most providers, when you go in for a complete physical, are going to get you to do a urine test. And most people who say you don't go for a physical, but you've got diabetes or hypertension, usually about once a year, every 2 years, somebody's going to check a urine. Mainly just see how healthy your kidneys are. If they find too much red blood cells in the urine, then that means you need to be looking in the urinary tract system for cancer. Doesn't mean you got it. Could have a kidney stone, could have a kidney infection. Some people just put blood in their urine normally. I mean, that's just what some people do. Some people do it after they run. So you have to keep all that in mind. And the urinary system includes, it starts with the kidney, goes down the tube to the bladder. So, and then of course the prostate, but we'll talk about that later. Now, some chemical exposures used to people who did certain type of printer's ink. I think they took the chemical out of printer's ink. They had a lot of bladder cancer. People in the printing business used to. So, now colon cancer. Now this is one a lot of us know about because colonoscopies have been around for a while now. So let's see what the U.S. Preventative Task Force recommends here. They recommend several ways you can do it. Fecal occult blood testing. Now if you have a hemoccult test and it's positive, statistically you got a 1 in 20 chance of having colon cancer. That's not very good, is it? So 19 times out of 20. Probably the best thing about a positive hemoccult test is it was a way to get people to get a colonoscopy and get it covered by insurance. Because years ago, insurance didn't cover a colonoscopy unless you had a problem. That changed when these screening recommendations came out. Sigmoidoscopy is where you just look at the lower part of the colon. Colonoscopy is looking at the full colon. They recommend beginning at age 50 and continue to age 75. They're not going in. Most people, if you have a negative test, you go again in 10 years. If they find an adenomatous polyp, you go every 5. When I did my first screening colonoscopy, they found 4 precancerous polyps. I had no symptoms. When I did my second colonoscopy, they found 1. And I told him, I said, I was hoping you'd find none so I could go 10 years. And he told me, no, you never go 10 years. You go 5 years. So.
That's just if you don't have family history, right?
Right. That's right. Family history may make it different. Interesting, both my mom and dad had colon polyps. They never had cancer, but they had precancerous polyps. So. Oh, wow. Yeah. Well, if he had somebody in his family say he had colon cancer at age 40, a lot of people say go 10 years early. Yeah. Oh, okay. Okay. Wow. Yeah. And there is a subset of, I actually had one patient, she's no longer alive, but who had multiple polyps. If you look in their colon, they got like thousands of them. They usually recommend a full colon excision, take the colon out on those patients because you're going to get colon cancer. And that's an inherited condition. It's rare, but it's inherited. And their colons are just loaded with polyps.
They recommended our son be tested at age 13. But
Wow.
then that was,
Right.
I mean, he was maybe 5 or something.
Wow.
And by the time
Right.
I took him, as soon as he turned 13.
Yeah.
And at that time, it was a different doctor.
Right.
Different doctors.
Right.
They didn't do it.
Well, and a lot of these recommendations continue to evolve. That's so. Now, for adults 76 to 85, they recommend against screening. But they say there may be some things where you need to consider it in individual patient. For people over 85, they recommend against screening.
How come? Is that just because?
Well, let's say I've even told patients after age 80, because even in this age group, 76 to 85, saying you need to think about it. Let's look. I mean, this same question comes up with like mammograms and even prostate. Let's say you're 83 years old and you have a tiny little polyp that may become a cancer over the next 10 to 20 years. Let's say you're a woman who's 83 and you've always had normal mammograms and now you've got a tiny little thing on a mammogram at age 83 that may kill you in another 15 or 20 years. Let's say you find a small prostate cancer. If you're 83 years old and you're a man, you got about an 80% of men having a prostate cancer at age 83. Somewhere in there, 75, 80%, if you look hard enough.
Well, that sounds fine unless you're 80.
Huh?
Yeah.
That says my grandma.
Yeah, that's right. So, but the thing of it is, the problem you get to worry about, can we hurt these patients and can we bring their death forward because we did something? You know, let's say they go to surgery, they die from complications of anesthesia. And you think, well, they probably lived with that problem another 10, 15 years.
Yeah.
And they probably wouldn't have made it that long. Something else would have killed them. So there is no automatic age whether you flip that switch. So we arbitrarily pick ages. But if you got a person who looks like they're going to live to be 110, and not many people do, but my oldest patient right now, she's headed for 101 in May.
Wow.
I took care of her mother who was 104 when she died. Wow. And I think this lady would have beat her mother, and she may still beat her mother. But I haven't been able to get her to quit smoking yet.
Yeah.
So. Yeah. Now, her smoking still hurt her because she has such severe macular degeneration she can't see me when she comes in. She knows I'm in the room. And smoking also can cause macular degeneration. So it's one of the risk factors for that. All right. Now, testing for colon cancer. Here's some ways you can do it. Flex sig every 5 years. If it's positive, you've got to have a colonoscopy. Colonoscopy every 10 years. Double contrast Barry minima. Now, I tell you what, given the choice between a Barry minima and a colonoscopy, go for the colonoscopy every time. Trust me. virtual colonoscopy, I don't know a lot of that being done. I don't know what the cost is. I'm sure there's centers where you can get that done at. We may see more of that in the future, but again, you've got to be concerned. This has radiation exposure. None of those do. Well, the Barry minima does, yeah. The Barry minima has radiation exposure. Then there's the hemoccult card. We talked about that. There's the fecal immunochemical test called the FIT test. That's one you take home, and it's kind of somewhat like a hemoccult card. This is interesting. This is a new one. We've just got the paperwork to fill out for this. I was relieved to find out that we didn't have to collect this specimen from our patient. Because actually this company, when you do it, and now Medicare's approved this every 3 years for screening for colon cancer, it actually, what they do, you collect a bag of poop and you mail it to them. And they can, that's the reason I was greatly relieved. I said, look, I don't want to do this test if I've got to collect a bag of poop and mail it to you. Because my staff will not, I'll have people leaving. Nobody want to work there anymore. But this test is supposed to be pretty doggone good about
So
picking
you
up.
send it to the mail?
That's what you do.
The
Yep.
US mail?
Yep. Well, it's full of you know what anyway, so. All right.
Just give it to the mailman.
There you go. That's right. But if any of these tests are positive, you got to have a colonoscopy. But this may be, the other thing concern I always have a concern when it comes up with all these tests is how much this test costs and does insurance cover it? Because you can say, oh, just do this stool test, and next thing you know, your patient's got a bill from the lab for $585, and they're like, my colonoscopy would have been covered. So you always check your cost on things like that. Medicare's supposed to cover that every 3 years. I'm not sure about the other insurances right now. So at least these have pretty standard guidelines there. So, and a lot has to do with your age, your family history, and things like that. People with family history of colon cancer, you do it early. I'm going to kind of skip through this. We've already talked about that. Ladies first, okay? Let's hear from 3 organizations about breast cancer. Now that's interesting. We got 3 different recommendations about breast cancer. This is from ACOG, American Congress of Obstetricians and Gynecologists. Age 40 is when you start. Women 29 to 39 should have a breast exam every 1 to 3 years. That means at the doctor's office. Women age 40 and older should have one every year. That's what ACOG recommends. The traditional self-breast examination, let's see, I'm trying to remember which group recommends what. A lot of them have gone away from this now. They don't recommend you examine your breast once a month or with a precise method. Instead, it focuses on a sense of what's normal in your breast, or even small changes. If you don't check them, I don't know how you know. I do have patients who tell me, it's kind of like their body talks to them. I know what's going on in my body. Well, I've seen those people come down with things that they didn't know was going on, but I don't know how you're going to know what's normal unless you look at your breast periodically and you check the breast. So, one of the problems they had with recommending women to check their breast, there's a certain number of women who get paranoid, get obsessive compulsive about checking the breast. They're checking the breast 4 times a day. They go to the doctor every 2 weeks with a breast mass. So that was, I'm exaggerating, but that's some of the problems we run into with having women check their own breast. And it got where, okay, there's too much anxiety over women doing self-breast exams, so tell them to quit doing it. I guess it was driving the doctors crazy. I don't know. So, American Cancer Society, another group here, yearly mammogram starting at age 40, same as you heard before. Clinical breast exam about every 3 years in their 20s to 30s, and every year for women 40 and over. Women should know how their breasts normally look and feel and report any change. Breast self-exam is an option for women starting in their 20s. And then it mentions here some women, because of family history, genetic tendency, or other factors, should be screened with an MRI in addition to mammograms. I haven't seen a lot of that done around here. And that's a small category of women that need that. We're going to talk some about that. This is, how many of you heard of BRCA testing? Okay. The BRCA mutation puts women, when you hear a woman who's 32 years old and has breast cancer, she's probably got a BRCA gene. When you hear a woman's 28 and she has ovarian cancer, she's probably got a BRCA gene. When you hear a man's got breast cancer, he's probably got a BRCA gene. So when you're in families where you hear that kind of thing, you should probably be tested for BRCA genes. And it's genetics, and it's about a genetic mutation. So we're going to try to cover that pretty fast. It was, BRCA1 was discovered about 20 years ago. It's obviously been around, but BRCA2, there's BRCA1 and BRCA2 genes. Just as a review, every cell in your body contains genes. They're the blueprints for your body. Everybody knows that's how you get your color of your skin, your eyes, your hair, and your shape and size tendencies. And genes pass on from one generation to the next. Now, if something messes up in a genetic code, you call that a mutation. Mutations are fortunately rare, but when you pass a mutation from one generation to the next generation to the next generation, those mutations sometimes cause problems. So, and that's what we have found in the BRCA, which means breast cancer genes 1 and 2, and they're the ones best known to be linked to breast cancer. There's probably other genes like this around that we haven't identified yet. I mean, this is relatively new science. But people who have BRCA1 or BRCA2 have a greatly increased risk for breast cancer and for women, ovarian cancer. So So let's look at this now. This is the U.S. Preventative Task Force. BRCA1 and 2 test is not recommended for all women whose family history not increased with increased risk for that. This is more important probably for us to know. Autosomal is not sex. It's not sex chromosomes. It's autosomes. Dominant pattern. It means if you get one from your mom and none from your dad, it's dominant. So you still got the problem. Okay. 2 to 7% of breast cancer, 10 to 15% of ovarian cancer is a result of this. So not everybody's got breast cancer who's got this. Most people don't. Women who carry the mutations have a 45 to 90% lifetime risk of breast cancer. You may have heard there's some movie star, I think, which she ended up with tested positive for BRCA and got both breasts removed. Right. I mean, because she knew she was going to get breast cancer. So she decided to just go ahead and do away with it. All right, with half of them before age 50. And the risk of ovarian cancer with a mutation is 30-fold the general population. That's really high. Now, you recommend testing for this with a family history of breast, ovarian, tubal cancer, or peritoneal cancer. And these need to be, you need to look at this way. Breast cancer was diagnosed before age 50, ovarian cancer diagnosed at any age. So if you had a relative with ovarian cancer, you might want to consider BRCA testing, particularly for a young woman. Both breast and ovarian cancer in the same person. Got to be very much suspicious of a BRCA gene. I've actually seen that where people had both of these. Bilateral multiple primary breast cancers. This is always hard to pronounce. Looks like Nazis. Ashkenazis, right?
Ashkenazi.
Is that how you say it? Okay, good. Jewish heritage. Now they have a risk of breast cancer and ovarian cancer. So, and some of I think some of that is just, that's a very narrow group.
It is.
So there's a lot of, it gets close to the problems we worry about inbreeding. When people are too close to each other, the mutations can survive better that way. All right, so presence of male breast cancer, a known BRCA1 or BRCA2 in a family member, breast cancer diagnosed prior to age 60 with triple negative pathology, estrogen receptor positive, progesterone receptor positive, HER2 negative, negative. If somebody's had that, that would indicate you need to look for BRCA. All right. Now, this continues with the U.S. Preventive Task Force. Breast cancer screening recommended for women 50 to 74 every 2 years. And then they say breast cancer screening with mammography for women 49 is uncertain every 2 years. They don't know. Maybe you should do it every 2 years. Individual decision. Breast cancer teaching breast self-exam is not recommended. And breast cancer clinical breast exam beyond mammography in women 40 and older has insufficient evidence to assess benefit. So what they're saying there is they don't see any benefit in having a breast exam compared to having a mammogram. That's interesting because on most of the mammograms, one of the things the radiologists put on there for us is just because the mammogram is negative doesn't mean the woman can't have breast cancer. It's a little CYA, I get everywhere you go, you know. So. All right, the bottom line. We must continually sort through new information, already accepted information, maintain continued practice early detection, prevention, diagnosis of disease, and we have to cooperate together. And this is another thing that factors in, the rules of the insurance company, what's covered. You know, because that definitely factors into it for patients. All right, doctor and patient can make these decisions. Cervical cancer. Actually, if we read one of these, all three of these look pretty much alike. They're pretty close. But these three organizations told us how to screen for cervical cancer. If you've had a hysterectomy, you don't need to worry about that anymore. And over 65, basically, you don't need to worry about that anymore. So they don't recommend any more starting until age 21 with pap smears. You remember years ago, you used to, if you're going to get a birth control pill, you got to have pap smear. No, you don't need that. So at age 21, you start doing it. Age of 21, 29, pap every 3 years. Women 30 to 65 should have a pap smear and human papillomavirus testing, co-testing. If that's normal pap smear negative HPV, they can be screened every 5 years. So I don't know what the gynecologist is going to do nowadays. Deliver babies mostly, I guess. But then you don't need to have pap smears all the time. I can remember years and years ago when I was a kid, I remember women sometimes going every 6 months to get pap smears. Does anybody remember that? At least annually. A lot of people went annually. So, yeah. Now, you can stop. Yeah, that's right. That's right. A lot of the gynecologists have not made these changes yet. You can stop having cervical cancer screening after age 65 if you haven't had any problems. And they're explained here. If you've been having negative pap smears, you don't need to keep doing them after age 65. Now, this American Cancer Society, this is basically very close to the same. So I'm going to move on there. But it does say here, even women who've been vaccinated against human papillomavirus, you know, the women are getting that nowadays, Gardasil, they still should follow the same screening recommendations. So, and this is the U.S. Preventative Task Force. Again, it's basically the same kind of thing. They worded it a little different. But they're about the same. So women 21 to 29 every 3 years, 30 to 65. Pap test with HPV test is preferred. And you can do it every 5 years as long as they're negative. Now, if they're positive and problems are coming up, the doctor should tell you how often you need to be checked. And you can stop screening if everything's been negative at age 65. Give you something to look forward to. Just like looking forward to a colonoscopy every few years. It's trade-off. All right. Now, ovarian cancer, with the exception of these BRCA things, there's no screening for ovarian cancer. Even the physical exam doesn't do a good job of picking up ovarian cancer. There is no good screening. This test gets a lot of publicity. It's used as a cancer marker test for women who have ovarian cancer. It is like flipping a coin, though, and using it for screening. It is not a good screening test, despite what Ladies' Home Journal says. So the U.S. Preventative Task Force recommends skin screening for ovarian cancer. So there's no real screening test right now. There's research being done about that. But endometrial cancer, there's no screening for that. Uterine cancer. Now, the key thing right here that women need to know, particularly after menopause, if you have bleeding and think you're having another period, you need to be checked out because that's abnormal. That's the main message we need to tell women when their periods have stopped. If you have another period, now sometimes around the time of menopause, women will pause for maybe a couple months and have another period. But when you've got a woman who stopped her periods 3 years ago, and then she comes in and says, "Doc, I'm having a period," that needs to be thoroughly investigated. And that's when a lot of times and it still could be benign. I had a woman recently, she's done this twice in 2 years, and she's way past menopause, twice in 2 years, and both times everything comes back benign. So, but it needs to be checked out. And that's what this says right there. Now we're going to talk about men next, prostate and testicular. Prostate cancer is really getting tricky lately. If you'll look at this, the U.S. Preventative Task Force, remember that's the one the government has, they recommend against using PSA as a screening test for prostate cancer. They don't recommend doing a PSA. They don't even recommend doing an exam. I don't know how we're supposed to find prostate cancer, according to them. Because prostate cancer, many times the first symptom of a man with prostate cancer, if you didn't screen him, is, "Doc, my low back and my hips are killing me." That's because he got metastatic bone cancer from his prostate. So the idea from screening is trying not to get to that point. Now, it could also be, it depends on what location in the prostate the thing grows. If it grows near the little tube you pee through, could have a man come and says, "Doc, I can't pee good." But most of the time, that's just an enlarged gland. But if it's enlarged from cancer, it could do that. All right, American Cancer Society recommends that men make an informed decision with their doctor about whether to be tested. It says research has not yet proven the potential benefits of testing outweighing the harms of testing and treatment. The American Cancer Society believes that men should not be tested without learning what we know and don't know about the risk and possible benefits of testing and treatment. So they say start at age 50, talk to your doctor about the pros and cons. However, African American men, or if you have a father or brother who had prostate cancer before age 65, these men should talk to the doctor about age 45. If men decide to be tested, they should have the PSA blood test with or without a rectal exam. How often they test will depend on their PSA level. So if the PSA is higher, you test them more, according to the American Cancer Society. Now, I have had, over the years, over 30 years, several white men in their 40s who don't meet these screening requirements, even if we did them, who had abnormal PSAs and had prostate cancer and had radical prostatectomies that hopefully cured their prostate cancer. So, but again, this is looking at population-based studies. So, let's look at the American Urological Association. These are the doctors who do prostate cancer surgeries and treatments. They've released 5 guidelines. They recommend against PSA screening men under 40. That makes sense. It's always interesting to me. Sometimes I get notes from other offices, and I see a guy who's 30 years old, and he's had 3 PSAs already. And I'm like, why? I mean, nobody would recommend that. I don't understand that. I think it's just a panel of tests somebody ordered. All right. It says in this age group, the prevalence is so low that the likely benefit is really bad. Well, the chances are if you found an abnormal test, they probably still don't have prostate cancer. So, they don't recommend routine screening men 40 to 54. For men younger than 55 at higher risk, again, family history, African American race, decisions regarding prostate cancer should be individualized. 55 to 69, this is where they think most of the problems are, but it says here, do PSA testing, preventing 1 prostate cancer mortality, death, for every 1,000 men. Now for that one man, that's important, but for every 1,000 men, if you're testing 1,000 men, you're going to maybe save 1 of them. So they strongly recommend shared decision-making for men 55 to 69. And then that's where the greatest benefit will be, is in that age group. They also mentioned this, a routine screening interval of 2 years or more may be preferred over annual screening. It would preserve the majority of the benefits and reduce overdiagnosis and false positives. And additionally, intervals for rescreening can be individualized by a baseline PSA level. So one of the things I found over the years in testing men, because I've typically started at age 50, I think the best way to follow PSAs, if you do them, I've been doing them every year, if a man comes in every year to have them done, is you can kind of track where they're at and watch their pattern. If they have a certain blip in it where it goes up too much, could be cancer, but you can also treat for possible infection a lot of times and just test them again in a few months. So the key thing is for the doctor and patient not to panic and recheck it in a few months, because most of the time prostate cancer is a very indolent cancer, which is one reason you got a lot of time to deal with it. It's rare that it's aggressive. The men who I think have the biggest problem, if men who have an enlarged gland, their PSAs tend to run high, and their PSAs can jump all over the place. One year it's 4, next year it's 7, next year it's 6.5, then it's 12. A lot of times it means they got an infection. It doesn't mean they have cancer. But that's the ones I think that make this thing where a lot of those men I've seen men get 6 or 7 biopsies done over the last 5 years, and you're like, and they're all negative. So they don't recommend PSA screening men over 70 or any man with less than 10 to 15 year life expectancy. Then they say if you're over 70 and you're really good health, you might want to consider doing it. So again, if you think you're going to live to be 100, but who's got a crystal ball? I know. Trust me, I'm in the business. This gets confusing. When you're the doctor out there, because to me, family practice and primary care doctors, we're like the Marines. We're out there on the front line. All we want is these experts to make up the cotton picking mine. So, and we don't want government influences. One thing you're always scared of, the people who pay bills, that's insurance companies and government, a lot of times drive decisions. And we're out there dealing with, when I see a patient, you're my patient, you're my individual, my care is about you. Not your insurance company, not Medicare, not the government. My concern is what can I do to help you the best I can? And you can see it can be complex. Okay, now testicular cancer, the bottom line is here, because it's getting late, there is no recommended screening for testicular cancer. Now, I will tell you when boys come in for their sports physicals in school, and they come in for their school physicals, mom brings them in, I check for hernias, I check a testicular exam. And I usually tell the boys, boys fiddle with themselves a lot anyway in the teenage years. So I tell them, if you feel like you got a golf ball growing on your testicle, you might need to tell somebody. So I don't see a problem with asking them to screen themselves, because, I used to do a lot of physical exams for snapper. And I had a guy come in one time for his snapper pre-employment. I'm checking for a hernia. He's got a testicular mass bigger than his testicle. I mean, it's like a baseball. And I'm thinking, how long's that thing been there? I don't know. Have you noticed this thing growing down here? I don't know. And I'm like, you know, and he may be dead by then. I mean, it may have spread by then. So, since he wasn't really my patient, he was a snapper pre-employment, I just had to tell him, look, this is what you got to do. You got to go see somebody. You got to get this thing taken care of. The other thing that I remember a number of years ago, when I was early on in my practice, typically to help the local funeral home out, sometimes they'd bring their car by when somebody had died, because a doctor's got to pronounce you dead if you're dead. And to save them a trip to the emergency room, they just come by my office. I didn't charge anything for it. It's just public service, I guess. But I went out there one day, so I'm in the middle of my busy clinic. It's about 4:30 in the afternoon. I go crawl into the hearse with my stethoscope, and there's a 13-year-old boy laying in there. And at home, I had a 13-year-old son. And here's this 13-year-old boy, dead, and color wasn't good. And I said, what was wrong with this young man? He died from testicular cancer. At age 13. He died from testicular cancer. So ever since that day, I've always made sure, when I'm doing a physical on Mandy's, I ask him, I say, you got boys at home? Yep. How old are they? If they're teenagers, I don't tell them when they're 4 or 5 years old, but if they're teenagers, I say, look, just tell them to check themselves every now and then. If they find something growing, just make sure you get it checked. Of course, they may find something else growing, right? Growing on their testicle. That's right, that's right, that's right. Something growing on the testicle. It only matters if it's on the testicle. Other organs do not matter. But there is no recommendation. This goes through all the different societies here. There is no recommendation to screen for testicular cancer. Despite the fact, and if you look at it, that's one of the cancers that young men get. Older men don't get it very much. Jim Valvano, if anybody remembers him, he died from it. But you hear of like you hear a lot of athletes, Lance Armstrong. I mean, you hear a lot of the younger athletes having it. You don't hear much about older men having it. So, but again, there's no recommendation. So as we see, it's not easy to know. So what does this mean for me? And I'm going to give y'all this handout. And then this talk will be available to y'all. And you can look at, all these things have websites. You can go to the U.S. Preventative Task Force website. Most of y'all out here are real computer savvy. So, American Cancer Society, that's another site you can go to, and look at what the screening recommendations are. And if you go and you think, well, I don't think that's what my doctor's going by, you can see where it can be confusing. A lot of times doctors go by the way they've been trained, and we tend to do things the way we've been doing them. So when new screening recommendations come out, it usually takes a while for patients and doctors to kind of make the adjustment. Because we're creatures of habit, we trust this way of doing things, that's the way we've done it. It takes us a while to change our ways of doing things. And the other concern physicians have is you've seen things cycle. Somebody say, don't do this, and then a few years later they come back and say, well, we really should have been doing that. I read an article published by John Hopkins, I think it was. I had sometimes in men started doing PSA testing, particularly in African American men at 40 and white men at 45. And that they wrote an article, it was in the Wall Street Journal, and said, you know, I think maybe we should be doing PSA testing when men are a little younger. Because, you know, picking it up. Like I said, I've had several patients. I remember a patient and his wife coming in, I don't drink wine, I don't drink any alcohol, but they brought me some wine and some, I don't know, fruit basket or something. Because when they went to the urologist, they said, your primary care doctor saved your life by doing a PSA. He was only in his 40s. He had no clue he had a problem. But he had prostate cancer. So, but again, that's one patient. That may not be enough. So it does get complicated. So the patient, you should let your doctors know what you want to do. The biggest problem you got, if you want to do something outside the norm, it may not be covered by your insurance. And that's one reason a lot of times doctors get afraid to order things, because they don't like patients screaming at them because the insurance didn't cover it. One thing is we learned quickly, people want us to do everything until the bill comes.
Yeah.
And then, why did you do that? I didn't need that. I mean, I've had that happen. Patients or the wife of a man say, you didn't need to do that test. I said, well, I thought I did when he was there. So, you know, but that's part of how these things are affected. Any questions?